You know, we really like the jagged line on an X-ray
Oh, yeah. Yeah.
because it just tells us exactly what to fix, right? You look at the film, you see the break in the bone, and the path forward is, well, it's purely mechanical.
Right. You cast it, you wait 6 weeks, and you're done.
Exactly. But when you step into the world of like neurodevelopment or trauma or mental health recovery, that X-ray machine is just broken.
Yeah. There's no clear picture at all.
Right. Instead, we have the system that kind of just warehouses patients on autopilot. It checks the regulatory boxes, and we just watch clinicians burn out at terrifying rates.
It's a huge problem.
So today, we are taking a deep dive into an entirely new operating system for mental health recovery.
Yeah, it's a really comprehensive framework from the Social Interest Consulting Group, or SICG.
And I want to be super clear about our mission today. If
Yeah.
you are listening to this and you're a student, learning the ropes of clinical care or preparing to walk onto the residential floor, this deep dive is for you. We're going to give you the exact blueprint to navigate those murky waters, stop the burnout, and actually prove that you can systematically manufacture hope.
Yeah, and the ambition of this SICG framework is it's pretty massive. It wants to completely rewire how residential care operates.
Which sounds impossible, honestly.
Right.
Yeah.
But it's fundamentally about aligning clinical excellence with regulatory compliance. Because, in the real world, if you can't survive the state audits and the census pressures,
You can't keep the doors open.
exactly, you can't keep the doors open to do the actual clinical work. So this operating system is designed to assess, remediate, and sustain recovery by fixing the institutional environment.
So the clinician can actually focus entirely on the human being sitting right in front of them.
Right.
But before we dig into the cure, I feel like we have to look at the disease.
Oh, definitely.
The sources we're looking at describe the current institutional status quo as this. They call it the triangular cycle of mutual discouragement.
Which is a very academic way of saying that literally everybody in the building is losing.
Yeah, right. So break that down for us. What is this cycle?
So it's a self-perpetuating cycle of failure.
Mhm.
At the first point of the triangle, you have the consumers, the patients,
Okay.
and they disengage almost immediately. And why? Because they're handed these generic, clinician-imposed treatment goals that have, like, zero relevance to their actual daily lives.
Right, like reduce symptom severity by 20%, which means nothing to them.
Exactly. And then at the second point, you have the clinicians. I mean, these are people who enter the field with immense passion, but they just get crushed
By the paperwork.
by an absolute avalanche of administrative burden. They spend all their time charting for auditors. So the actual progress they make with a patient, it goes completely unmeasured. It's invisible.
So they burn out.
They burn out. And then the third point is the administration. They fall into what the framework calls goal displacement.
Meaning they forget why they're there.
Yeah, they completely lose the thread of clinical care because they are just in survival mode.
Right.
They start optimizing purely for census maintenance, keeping the beds full and checking off regulatory compliance boxes.
And that leads directly to that warehousing effect we talked about.
Right. Patients are kept physically safe, but there's no trajectory toward actual recovery.
It's like being trapped in a car with a GPS that only tells you, your final destination is 500 miles away, but it flat out refuses to give you turn-by-turn directions.
That is a perfect analogy.
The patient's in the passenger seat, the clinician's driving, the administrator is paying for the gas, and everyone is just driving in frustrated circles.
Yeah. And to break that cycle, this framework relies on a massive paradigm shift.
Mm.
And it's rooted in Adlerian psychology.
Okay.
They define recovery with a very specific equation. Recovery equals home plus purpose plus community.
So it's not just symptoms managed,
No, the framework actively rejects what they call deficit cataloging.
which is basically what traditional medicine does, right?
Oh yeah. Traditional medicine loves to start by listing everything that is broken about a person. Adlerian psychology takes the complete opposite approach.
No, so.
It maps a person's style of life to identify their existing strengths. The foundational belief is that an individual's wellness is inseparable from their contribution to a community. Adler called this social interest.
Right.
Wellness isn't just the absence of symptoms. It's active, purposeful participation in a community.
And the sources mention a concept here called fictional finalism,
Yes.
so instead of opening a new patient's file and reviewing their whole history of relapses or trauma, you're asking someone who is probably in acute distress to just invent a future version of themselves.
It does sound incredibly abstract at
Yeah, I
first.
mean, how does a clinical student actually ground that on day one?
Well, fictional finalism is simply the imagined future self that drives a person's current behavior. If you ask a consumer what is wrong with them, you reinforce their identity as a patient.
Oh, wow. Yeah.
But if you ask them who they want to be like, maybe they want to be a reliable father or someone who can hold down a job at a bakery, you immediately establish a concrete anchor.
Yeah, it makes a lot of sense.
The clinician's job isn't to fix the past. It's to empower the consumer to map a measurable pathway to that fictional finalism.
So you ask, like, what is the very first microscopic step we can take today to get closer to that version of you?
Exactly.
Okay, so if you are sitting across from a new admission tomorrow, that is where you start. You don't lead with the deficit catalog. You identify the future self.
Right.
But let's back up a step, because just getting that patient into the room safely is a massive hurdle on its own.
Oh, absolutely.
The framework outlines phase one of the consumer journey pipeline, which focuses on admission integrity. And it uses a whole suite of instruments before the patient even unpacks their bags.
Yeah, protecting the therapeutic environment starts at the gate.
Yeah.
The admission phase uses a sequential set of checks. You aren't just looking at basic demographic info.
Right.
You're running rigorous pre-admission risk screens. The PRAS to catch active suicidality, severe withdrawal risk, or, a history of violence that the facility simply cannot manage.
And this all leads to a final decision.
Yeah, the SICG-PAS-ES. It culminates in a final admission decision that requires a formal sign-off from an LPHA, a licensed practitioner of the healing arts.
But wait, doesn't front-loading all that friction, all those acronyms and assessments, just delay care?
I see why you think that.
If someone is in crisis and needs a bed right now, putting them through a 3-step bureaucratic filter seems totally counterintuitive.
But the friction is the point. That LPHA sign-off operates as a binding clinical promise.
A promise.
Yes. It prevents the administration from succumbing to that census pressure we talked about. You can't just fill an empty bed to keep the revenue flowing if your facility is not clinically equipped to handle that specific individual's acuity level.
Because that would just be setting everyone up to fail.
Exactly. Bringing someone into an environment that cannot support them doesn't provide care. It guarantees a failed placement, and it further traumatizes the consumer.
So this introduces a really powerful tool for those of you dealing with complex admissions. It's called the Approve with Conditions pathway.
Right.
When you are evaluating a tough case, you don't have to just issue a binary pass or fail. You can admit them under very specific, documented terms.
It forces total accountability. You are communicating to the referral source, the facility, and the consumer. We will admit you, but only on the condition that we secure this specific group therapy slot.
Or like guaranteeing one-to-one staffing for the first 48 hours.
Exactly. It mandates that the facility actually builds the scaffolding before the consumer steps onto it.
Wow. Okay, so once they're in the door with that scaffolding in place, we get to the daily grind.
Right.
How do you measure the day-to-day needs of a patient without reducing their whole complex life to a simple pass or fail grade?
So the framework answers this with the LAS staircase, the level of assistance scale.
And this goes from 0 to 4, right?
It does. Let's walk through how this actually looks on the floor. Imagine a consumer trying to manage their morning medication and hygiene routine.
Okay, simple enough.
At the bottom of the staircase is a 4, which indicates a safety risk or complete dependence. The staff is essentially doing the task for them just to ensure safety.
Got it. And what's a 3?
A step up is a 3, which is active intervention. The staff member is in the room, maybe physically guiding the action or heavily managing the environment.
Okay, so then a level 2 would be specific cueing. Like the staff member isn't managing the whole environment, but they're giving detailed prompts.
Right, like did you take the blue pill? Have you brushed your teeth?
And level 1 is global cueing. You just stick your head in the door and say, hey, did you finish your morning routine?
Exactly. And a level 0 means the consumer is completely independent.
Okay, that makes sense.
But here is the most crucial conceptual shift in this entire framework.
Okay, what is it?
Traditionally, if a consumer scores a 3 and requires active intervention just to get dressed, the system views that score as a measure of the consumer's pathology.
Oh, like it's a judgment of how broken they are.
Exactly.
Yeah.
But this framework explicitly redefines a score of 3 as an environmental bridge.
An environmental bridge. That reframing changes everything about the dynamic of care.
It really does.
Because it isn't a grade on the patient's soul, it's a structural requirement. It literally tells the facility, this person isn't failing. This is simply the exact level of environmental support you must provide today to help them safely reach a level 2 tomorrow.
You nailed it. It removes the stigma and replaces it with an operational directive. And they pair this LAS staircase with goal attainment scaling, or GAS,
Right.
which completely dismantles that binary pass-fail mentality of traditional care. GAS uses a scale from -2 to +2.
Okay, so 0 is in the middle.
0 is the expected good enough outcome. +1 and 2 exceed expectations. But crucially, -2 is a failure to progress, while -1 indicates partial effort.
Okay, wait. I can hear traditional administrators balking at this right now.
I'm sure they do.
If we start handing out points for a -1, which literally just means partial effort, aren't we lowering the bar? Like, why are we celebrating someone for not actually reaching the goal?
Think of it like physical therapy for a stroke patient.
Okay.
If the goal is for the patient to lift a 5-pound weight and they can only manage to twitch their bicep, a binary system records that as a fail. 0 pounds lifted. No credit.
Because they didn't lift it.
Right. But a goal attainment scale measures the neural firing. It measures the twitch. Because if you don't validate that twitch, if you don't acknowledge the initiation of the behavior, the patient will never build the psychological muscle required to eventually lift the weight.
Oh, wow. That makes so much sense. A binary system erases effort.
Exactly. Which destroys motivation and feeds right back into that cycle of discouragement.
But GAS validates the partial effort, so if you are writing progress notes tomorrow, you use what the framework calls collaborative translation.
Yeah.
You write SMART goals, but you co-construct the behavioral anchors using the consumer's own words.
Right. You have to use their words.
So if the goal is attending group therapy, and they walk down the hall but can't bring themselves to actually enter the room, you don't write non-compliant.
No. Absolutely not. You log a -1 for partial effort, and you document that they needed level 2 specific cueing today. You validate the attempt.
But, human progress isn't a straight line.
Yeah.
You can validate partial effort, provide the perfect environmental bridge, and the momentum can still just stop.
Yeah, stagnation is a harsh reality in mental health recovery.
So you're tracking these micro wins, you're validating that partial effort. What happens when that momentum just flatlines?
Well, the framework introduces phase 3. The Recovery Progress Monitor, or RPM. You're tracking these GAS scores over time.
Okay.
And the RPM allows for a step-down support review. As the consumer succeeds, you systematically reduce the environmental bridge from a 2 to a 1. But when the scores stagnate well, the traditional instinct is highly predictable. If a patient doesn't improve for 2 months, the facility blames the patient. They're labeled unmotivated or treatment-resistant.
Yeah, we see that all the time. But under the SICG framework, that reaction is entirely dismantled.
Yes.
If a consumer's GAS scores remain flat for 2 consecutive months, it automatically triggers a stagnation early warning. And that warning is not directed at the patient.
Not at all. It is directed squarely at the facility.
Wow.
It mandates a treatment effectiveness review. It shifts the accountability from the consumer's supposed lack of willpower directly to the system's efficacy.
So the clinical team actually has to sit down and ask, is our environmental bridge failing?
Exactly. Are we providing specific cueing when they actually need active intervention? Are the goals we set still aligned with their fictional finalism?
So for the students listening, if you are on the floor tomorrow and you see a 2-month flatline, your lens has to shift. Your chart shouldn't say patient failed to progress. It should say our current treatment approach is failing to generate progress.
Yes. You have to figure out where the facility's scaffolding broke down.
That is huge. And when a facility holds itself to that level of systemic accountability, you start seeing actual verifiable outcomes.
You really do. And the framework ensures these aren't just empty numbers on a spreadsheet. It maps these daily living skills, what they call Domain 5 skills,
Yes.
directly to state mandates and transition readiness.
Right. This maps directly to things like the Williams Consent Decree. For anyone unfamiliar, these are state mandates that require institutions to prove a patient's actually ready to move out of a facility and into the community.
You can't just say, oh, they seem better. You need empirical proof.
And the LAS and GS data provide that proof. Financial management isn't just a subjective opinion anymore. It's documented data showing the consumer actively managing their own ABLE accounts.
Right. And transportation skills are validated by data showing they can independently navigate the bus system to reach their primary care provider.
Or technology use means coordinating community-based care.
Exactly. Resource access means they are actively engaging with ACT-assertive community treatment teams.
Which really cures institutional decision fatigue. I mean, no one wants to sign discharge papers if they have to guess whether a patient is ready.
Right. Here, you just look at the data.
And that leads to what the blueprint calls the climactic synthesis, which sounds like a movie title, but it's really important.
It is the core of the whole thing.
Usually we think of hope as this abstract emotion. We treat it like a prerequisite, like if a patient doesn't bring hope into the room on day one, we just assume we can't help them.
But the framework argues that hope is not a personality trait. It's a biological mechanism.
Wait, really?
Yeah. It provides an actual formula. Incremental GAS data plus an active mastery experience equals mesolimbic dopamine activation.
Okay, let's translate that into English for us.
Sure. So by explicitly graphing their progress, capturing all those negative ones, and validating the partial effort on the goal attainment scale, you create empirical, visual evidence of movement.
Right.
When a consumer engages in a task and experiences success, even if it's just partial success, they have an active mastery experience.
Okay.
When you combine that lived experience with the hard data proving they're moving forward, it physically fires the reward circuitry in the brain. It triggers dopamine release. You actually convert institutional stagnation into biological momentum.
You are systematically manufacturing empirical hope.
Yes.
So as a clinician, you literally turn the screen around. You show the patient their own graph, point to the visual trajectories and say, look, you are moving. The evidence is right here.
That data-backed encouragement builds their self-efficacy. It widens their psychological capacity to take on bigger challenges.
It's a profound shift in clinical care, but, and we have to address this, the operational reality is still out there.
Yes. Time.
Right. We established early on that clinicians are drowning in administrative burden. You cannot hold a master class on dopamine activation or collaborative goal translation if you have 40 progress notes due by 5 o'clock. Where does the time come from?
Well, the framework introduces what it calls the Tier 5 digital system. And it makes a very careful distinction here. This technology is not a surveillance tool.
Because in a lot of settings, digital system just means software that tracks a clinician's keystrokes or enforces billing quotas.
Which just adds more stress. But the Tier 5 system is designed as a protective shield. It's specifically engineered to absorb the robotic, administrative busywork.
Oh, that's amazing. So it pulls the compliance checklists, the census tracking, and the auditor requirements into the background via a live QPI dashboard.
Exactly. So instead of you spending 40 minutes formatting a progress note just to satisfy a state surveyor, the system's progress note assistant auto-structures the document based on your clinical inputs.
Wow. So by absorbing the robotic work, the digital shield protects what they call the relational container.
Right. That is the actual time and space where the clinician sits across from the consumer.
Because if you're staring at a screen trying to remember a diagnostic code, you cannot effectively use motivational interviewing. You can't read the patient's body language.
No, you're totally distracted.
You have to use the digital shield to handle the compliance so you can look the human being in the eye, calm their amygdala, engage their prefrontal cortex, and actually establish psychological safety.
And that's when the entire ecosystem finally aligns.
Everyone wins.
Yes. Consumers reclaim their agency and generate empirical hope through transparent measurement. Clinicians see their effort validated and use the digital shield to prevent burnout.
Administration proves that high clinical quality and business sustainability are not mutually exclusive.
And regulators get the defensible, trackable data workflows they need to ensure public safety and state mandates are met.
It takes that murky diagnostic landscape we started with and replaces it with a highly functional structural architecture for recovery.
It does.
We don't need a perfectly clear X-ray if we have a better operating system. An operating system that stops measuring brokenness, starts building environmental bridges, and actually holds the facility accountable when progress stops.
It is truly a blueprint for treating the system so the system can treat the person.
Which brings up a final thought I want to leave you with as you head back to the clinic or the classroom. If this framework proves that hope is not some abstract magical feeling, if it is actually a biological mechanism that you can systematically manufacture through transparent data and validated effort, how does that change your fundamental responsibility the next time a patient walks into your room and says they feel hopeless?
It changes everything.
You aren't just there to empathize with their hopelessness. You have the exact structural tools to biologically build their hope from the ground up.
That's powerful.
Thank you for joining us on this deep dive. Keep questioning the status quo, keep validating the effort, and keep applying these tools as you change lives on the floor.